Thank you, Dr. Capel, for the introduction, and to the organizers for inviting me to speak today. I have no disclosures. So I first, prior to going into indications for timed delivery, just wanted to take a moment to discuss delivery of the fetus with congenital heart disease in general for usual pregnancies. Of course, as we all know, this is a multidisciplinary decision that's made with our obstetrics, MFM colleagues, as well as neonatology and pediatric cardiology, of course. And I would argue that it's the most important decision that we make for patients and families after we have counseled them about the prognosis and they've decided to continue the pregnancy. So I think it's an important thing to discuss amongst ourselves. Now, just briefly, we often think about congenital heart disease lesions that we diagnose in utero as being non-ductal dependent or ductal dependent, and then the rest of the talk will be focused on the indications for timed delivery. So just as examples of the non-ductal dependent lesions, ventricular septal defect, AV canal, a mild tetralogy of Fallot, which we expect to have, quote, pink physiology, all of these types of lesions can be delivered locally at a community hospital if need be, with outpatient cardiology follow-up a week or so after the baby is born. Now, for ductal-dependent lesions, such as coarctation, a more severe form of tetralogy of Fallot with pulmonary atresia, or what I would refer to as standard risk hypoplastic left heart syndrome, there are some people that advocate that these patients may be delivered locally. However, I will say that there is a burgeoning amount of literature that suggests that all of these prostaglandin-dependent lesions for which neonatal cardiac surgery is anticipated really do have better outcomes when delivered at a tertiary care center, and I think that we will be moving in that direction. Now, in terms of when to deliver the fetus with congenital heart disease, this is an extremely important paper that was published by John Costello in Circulation several years ago, and I think has really changed the face of how we view delivery planning for all fetuses with congenital heart disease. He looked at almost 8,000 infants that underwent cardiac surgery at over 100 hospitals through the Society of Thoracic Surgeon database. And what they found was that when you looked at the adjusted odds ratio of mortality, which you can see here on the y-axis, versus gestational age at the time of birth on the x-axis, those fetuses that delivered between 39 and 40 weeks had the best outcome. And that outcome is not just the odds ratio for mortality, but also in terms of the nature of complications and length of neonatal hospital stay. And what's important, and what I think has been a change in practice over the past decade or so, when we used to deliver these fetuses at 37, 38 weeks, assuming they were full term, is that the odds ratio in terms of the mortality is almost twofold higher when you compare those delivered at 37 versus 39 and a half weeks. And I think it's a very important thing to note. So for the rest of the lecture, I'm going to be discussing what we think of as pediatric cardiologists, a timed delivery. And this means it's a delivery that requires very careful planning for lesions with hemodynamic instability or difficulty transitioning to postnatal life. And this doesn't necessarily mean that these are ductal-dependent lesions, and I'll discuss that a little bit further. Dr. Lindblad already gave me a head start by reviewing transitional physiology for you. So for timed delivery, we know that we need to have specialty care in the delivery room and or urgent catheter surgical-based intervention, and depending on the severity of the disease and what we anticipate, we also may have ECMO on standby, extracorporeal membrane oxygenation, which is a way of supporting a newborn through a heart-lung bypass machine if the cardiopulmonary system is failing altogether. So for a timed delivery, these, of course, must be at a tertiary care center, if not a quaternary care center, with critical providers on standby. And those include members of our team from the cardiac cath lab, cardiac surgery, and the ECMO perfusion team in certain cases, as I mentioned. Now, if the fetus is stable, and I'll sort of discuss the difference between what I mean by that, I would still argue that we should aim as close as possible to 39 weeks for the reasons that I mentioned previously. They still will have a better outcome following neonatal cardiac surgery. I also think it's very important to remember that when we say, as pediatric cardiologists, timed delivery, we don't necessarily mean a cesarean section. Now, some of that is very institution dependent. I'm fortunate to work at Columbia, where we have 24/7, high-risk OBs, cardiac cath lab availability, and we do not necessarily make these women deliver via C-section. But again, it depends on local resources. So in terms of lesions with hemodynamic instability and or arrhythmias, I'm not actually going to focus terribly on these. Dr. Lindblad already went through some evolution of cardiomyopathy, and then there's a dedicated session this afternoon to discuss fetal arrhythmias. But they are certainly lesions, cardiomyopathy, complete heart block, and tachyarrhythmias, for which you might anticipate there may be hemodynamic instability and efforts required in the delivery room, including hemodynamic support, intubation, and of course, treatment for the arrhythmia. But what I really want to focus on for the rest of the lecture is what I think are actually some of the most interesting and complex lesions pathophysiologically, which are the lesions that have difficulty transitioning. In other words, providing systemic oxygenation to the newborn immediately after placental separation. And so, again, Dr. Lindblad helped me a lot here by already reviewing transitional physiology for you. Of course, we have those 3 fetal cardiac shunts, which close within the first couple of minutes to days of life. But the main difference in thinking about this is that the fetus has to transition from the oxygen being delivered from the placenta to being inspired and circulated throughout the systemic circulation. And so what happens is that immediately when a newborn takes several breaths, the pulmonary vascular resistance immediately starts to fall. And as that happens, you have more antegrade flow throughout the pulmonary arteries and pulmonary venous return, which increases your left atrial pressure. And that, in concert with the clamping of the cord and an increased systemic vascular resistance, will cause closure of the foramen ovale. And that can really occur even prenatally, but of course within the first couple of seconds to minutes of life, which is why we like to think carefully about the lesions that are most at risk for inadequate systemic oxygenation if this closure were to occur quickly. The ductus, similarly, ductus arteriosus and ductus venosus both respond to oxygen but gradually constrict over the first couple of days of life typically and don't pose quite the same risk as the closure of the foramen ovale. So I'm going to discuss 4 lesions, some of which have been touched upon by Dr. Lindblad, which helps me a bit. And those are hypoplastic left heart syndrome with a restrictive or intact atrial septum, transposition of the great arteries, Epstein anomaly or tricuspid valve dysplasia, and tetralogy of Fallot with absent pulmonary valve. So again, HLHS with restrictive intact atrial septum. Dr. Lindblad already discussed how that atrial septum can get progressively smaller over the course of gestation. And just as a reminder of what he already showed you here, you've got a severely hypoplastic left ventricle. This is probably a case of mitral atresia, and then a diminutive ascending aorta with coarctation. And as the pulmonary veins, as the fetus is, the newborn, is taking the first couple of breaths, all of the oxygenation needs to transition from the placental to the pulmonary vascular bed. And so if you have all of your pulmonary veins with oxygen that are coming back here, they need to have a route of egress in order that there is systemic oxygenation of blood. Of course, that backup of pressure can also cause severe left atrial hypertension and pulmonary issues, but the real issue is that these infants can become acutely cyanotic and really die within the first couple of seconds of life in the most severe cases. So that atrial communication is a means for providing a route for systemic oxygenation to occur is essential for the survival of these children. And of course, in the absence of intervention, if a restrictive atrial septum is uncovered, it is a uniformly lethal condition due to lack of pulmonary vein egress, leading, as I mentioned, to profound cyanosis, acidosis, and death. And interestingly, this is in a series from CHOP, despite early intervention, there's a very high mortality that persists. And that has been thought to be due to elevated left atrial pressures in utero, which cause backup high pressures in the lungs, pulmonary vascular arteriopathies, and pulmonary parenchymal disease. And so the combination of complex single ventricle physiology and poor lungs is probably what accounts for the poor prognosis. In this series in CHOP, there's about a 50% mortality at 3 years. So now to get to the part that everybody likes, which is pictures. So here we can see this is a fetus with HLHS. So here is a right atrium, right ventricle. The left atrium is actually very dilated. And this structure, in fact, here is not a pericardial effusion, but it's a massively dilated left atrial appendage. There's no significant inflow across the mitral valve, and you've got a hypoplastic, hypertrophied, and severely dysfunctional left ventricle. So when I put color flow on it, again, you can see that this is atrial appendage, so massively dilated left atrium, consistent with left atrial hypertension due to lack of pulmonary vein egress. And then you can also see, as Dr. Lindblad also pointed out, as we often see in these fetuses, very dilated pulmonary veins. And even without the use of Doppler, you can see that there is reversal. And there's a way to quantify the degree of pulmonary vein reversal, which helps us to risk stratify some of these patients. And the bottom line is that you measure the velocity time integral tracing of the forward versus the reverse flow. The more reverse flow you have, the lower your ratio and the higher the likelihood of needing an urgent atrial septal intervention to open it immediately after birth. So this is that same patient who was born. This is an echo within the first couple of seconds of life. And you can see that there is a very thick atrial septum, which is bowing rightward, consistent with elevated left atrial pressure. And you can also appreciate that there are dilated pulmonary veins in the background. The actual echo clips, while this was being performed, were a little shaky, as you might imagine, as the baby was very unstable. But I'll tell you that this is the echo clip maybe 10 minutes later, after there was a stent placed within the atrial septum, and that allows for that oxygenated blood from the pulmonary veins to circulate to the right heart and provide the newborn with systemic oxygenation. So the planning for and the mode of emergent atrial septal intervention is very much institution dependent. There are some institutions that will advocate even for an exit procedure, in which case the baby is partly delivered, but while still attached to the placenta is cannulated intracardiac, and an atrial septostomy would be performed and subsequently the umbilical cord clamped. But I think most centers would advocate for delivery in or very close proximity to either the cardiac OR or the cath lab, and whether that's performed in an OR or cath lab is again an institutional difference. I want to also mention an evolving area of literature for helping to risk stratify fetuses in the third trimester, which is the use of maternal hyperoxygenation. And what maternal hyperoxygenation is administering 60 to 100% FiO2 to the mother for approximately 10 minutes. And this paper from CHOP actually looked at what happens in the pulmonary arteries as you deliver maternal hyperoxygenation. So in the third trimester, the fetal pulmonary vascular bed is responsive to oxygen. So what you would expect is that the pulmonary vascular resistance, which is measured by the pulsatility index, would fall. And if it falls with maternal hyperoxygenation, then you are reassured that there has not been interval development of a pulmonary vascular arteriopathy from increased left atrial pressure. Whereas if there's no significant change in the pulsatility index, then you do worry, that in fact there are changes that would indicate that this has been physiologically a highly restrictive or intact atrial septum and would warrant a more urgent intervention. So I'm going to transition now to talking about transposition of the great arteries, which in some ways the indications for timed delivery here are similar. And as you know, with transposition of the great arteries, we have two circulations which are in parallel rather than in series. You have all of your deoxygenated blood, which is going to circulate through your right ventricle and your systemic circulation, whereas your oxygenated blood is going to be circulating through your left ventricle and your pulmonary arterial bed. That obviously doesn't make for viable systemic oxygenation after placental separation. And so there needs to be a communication, an intracardiac communication, to allow for adequate mixing of oxygenated blood returning from the pulmonary veins and deoxygenated blood. It's important to note that although we always advocate for the initiation of prostaglandin in fetuses with transposition, largely with intact septum, although the same principles apply for those with the ventricular septal defect, it's important to note that a patent ductus arteriosus does not allow for adequate mixing. You really need to have an intracardiac shunt to allow for adequate systemic oxygenation to the newborn. And so therefore, we must rely on the opening of the maintenance of a patent foramen ovale in order to ensure mixing. If this were to close, then you can imagine profound cyanosis and acidosis would ensue relatively rapidly. And there were some cases yesterday where we looked at cases where this was not performed and the infants had severe hypoxic ischemic encephalopathies. So just an example of a transposition with intact septum. This is a relatively slow sweep, which I always like. But when you can see in the four-chamber view, it appears normal. The left ventricle subsequently gives rise to the pulmonary arteries, and the right ventricle gives rise to the aorta anteriorly. With color flow, you can see that you've got two parallel outflows, both of which are unobstructed in this fetus. And when you look carefully at the atrial septum and you turn down your scale and you lower your PRF, you really see that there is no appreciable shunting across the atrial septum, which is very concerning for inadequate mixing postnatally. And the other ominous sign in this particular fetus is when you look at the arches. So here you can see an unobstructed aortic arch. This red flow here is actually the LPA, and what you just see coming every once in a while is a little speck of flow, which is consistent with a small, restrictive, tiny restrictive ductus with bidirectional flow, which is a very ominous sign for the neonate being extremely unstable postnatally. So for those who haven't seen what we do for these infants in terms of performing a balloon atrial septostomy, again, how it's performed is a little bit institution dependent, but most of us will perform these at the bedside once the baby arrives to the cardiac unit. And a wire is placed through either umbilical or femoral vein access into the left atrium, and a balloon is subsequently placed across that wire, well positioned in the mid-left atrium, and then in a sort of barbaric fashion, it's pulled very quickly into the right atrium. Not exactly a precise science, but just enough to make sure that we have adequate mixing and viability with systemic oxygenation with this newborn. So here you can see now, of course, you have a nice atrial communication that's allowing for that oxygenated blood flow to enter the systemic circulation across the atrial communication. So predicting the need for the balloon atrial septostomy and transposition of the great arteries has been an extremely difficult task, and I think it's fair to say that there's no smoking gun. There have been multiple studies done over the past 2 decades trying to find the answer, and it turns out that it's just a very hard thing to predict. So there are very mixed results regarding the size of the atrial communication, the angle of the atrial septal primum, the hypermobility in terms of the prediction for needing urgent intervention. One thing that has been relatively consistent, though, is that an abnormal ductus arteriosus, such as the one I showed you, is likely an ominous sign. Now, Dr. D'Onofrio and colleagues had looked at a very large series of fetuses delivered at their center, and they looked at how well their fetal echo parameters were able to predict postnatally what the neonate required in terms of the level of care. And it turns out that for most fetuses, aside from those with transposition, they were able to predict relatively accurately what the neonate would need immediately after birth. But when you look at the sub-analysis of those in which they use the known fetal echo predictors for the need for a balloon atrial septostomy, the sensitivity was only 68% and the specificity 60%, suggesting that we are both under and overcalling the need for balloon atrial septostomy in these patients. And so I think the take-home message here is the effect of the transitional physiology on the foramen ovale closure is extremely unpredictable. But because these fetuses would get into a lot of trouble without an emergent atrial communication, our institution, and I know many other large institutions, adopt a uniform policy such that all fetuses with transposition should have a timed delivery for possible need for urgent BAS. So every transposition that we see, we deliver over 30 transpositions a year. We have timed delivery for all of them. At our center, that typically involves the mother coming in the evening before or the morning before for induction, and our cath lab on standby with planned delivery the next day at 39 weeks. So there is also some evolving literature that suggests that maternal hyperoxygenation in the third trimester, as I mentioned, can be useful in strategizing and in stratifying which fetuses may be more likely to require balloon atrial septostomy. In this situation, as we deliver the oxygen to the mother and there's increased flow across the pulmonary vascular bed and increased pulmonary venous return, we're looking at how much there remains left to right flow at the level of the foramen ovale. So at Columbia, we reported a series of patients in which we saw that if there was maintenance of a greater left to right shunting at the atrial septum with maternal hyperoxygenation, then we were more reassured that that foramen ovale would stay patent after delivery of the fetus. And I should say that there is an ongoing or early prospective study that's going to be looking at maternal hyperoxygenation and transposition across multiple centers, and we'll have some more refined data, hopefully to share with you soon. So I'm going to move on a little bit to talk about Epstein anomaly or tricuspid valve dysplasia. And the reason why I lump the two together is because pathophysiologically it's the same disease. It's the disease of severe tricuspid regurgitation in the fetus, which tends to be poorly tolerated. And they're oftentimes very difficult to distinguish in utero. But you have a structurally normal four-chamber heart with a very abnormal, in this case we're showing you an Epstein anomaly, which is a very apically displaced valve. And the pathophysiology of this disease is very unique, and some have coined the term a circle of death. And I'll just walk you through what that is with this cartoon. So due to the severity of tricuspid regurgitation, there unfortunately becomes a lack of antegrade blood flow, even in the absence of anatomic obstruction, and so what we call functional pulmonary atresia in some of these patients. And then, as a result, flow proceeds across the foramen ovale, right to left, as you would expect, through the left heart, but then at the level of the ductus, it's reversed, going left to right. And when you have the development of pulmonary regurgitation, that left to right shunting across the duct in the context of the functional pulmonary atresia really completes what we call this circle of death. And it's a source of extremely ineffective loading that causes cardiomegaly and then impaired systemic and ultimately pulmonary perfusion after the fetus is delivered. So to show you some examples, so this is a patient that came to see me in the third trimester, had been diagnosed with trisomy 21, and you can see, first of all, that the cardiac silhouette is markedly enlarged. You have a giant right atrium and a very abnormal tricuspid valve here, not particularly apically displaced necessarily, but you could see this very hypoplastic and rudimentary septal leaflet with a large anterior flail leaflet. And not surprisingly, with color Doppler, you can see that there is massive tricuspid regurgitation. And then in looking at the pulmonary arteries, you can see here you have retrograde flow coming across the main pulmonary artery and pulmonary regurgitation. So this is a very high-risk fetus with this circular shunting physiology that is going to unlikely to do well after birth and really needs a lot of thought into the delivery planning. Also, as a consequence of the tremendous cardiomegaly that we see, there are consequences in terms of lung compression, and these are courtesy of Dr. Turetsky at Boston Children's Hospital. These are some MRI images of a fetus with a ginormously enlarged heart here, where you can see that the lungs are compressed. And in this very neat 3D reconstruction, you really can appreciate how much the lungs become compressed as a result of this aberrant pathophysiology and how that may impact postnatal care. So we looked at a very large series across multiple centers of nearly 300 fetuses with Epstein anomaly. And not surprisingly, what you can see here, purple represents live-born death, blue represents live-born survival. You can see that fetuses that were delivered at a lower birth weight and at an earlier gestational age tended to have higher mortality than those delivered later. Now, delivery planning for these fetuses is a very complex issue because their pathophysiology can progress and hydrops can develop. So you may not be able to get to that 39 weeks as you may be able to for other lesions, but certainly the longer these fetuses stay in utero, the better in terms of outcome. What we also found in our large series was that we had an almost 10% mortality in the first 24 hours of life, with 32% mortality by neonatal discharge, suggesting that we have a lot of room for improvement in terms of our perinatal management strategies and postnatal care for these fetuses. Now, interestingly, non-survivors were slightly more likely to be delivered by cesarean section, and you can argue that that's because those fetuses were more sick, but I think that there was also not a significant difference as we might expect, and I think there is old school thinking that all of these fetuses need to be delivered by cesarean section. That may not, in fact, be the case. That being said, the optimal mode of delivery for these fetuses is unclear, but certainly neonatology and or cardiology need to be present in the delivery room with a low threshold for intubation because of the pulmonary issues, but more importantly, you want to initiate aggressive efforts to decrease pulmonary vascular resistance, such as the use of oxygen and nitric oxide, and the attempt to promote forward flow across the pulmonary valve and improve your systemic oxygenation. Prostaglandin may be used for select cases, but is not the first line of treatment for cyanosis in this disease because it's mostly due to lack of antegrade pulmonary blood flow in a functional way with concomitant lung pathology. And then, of course, in the most severe cases, ECMO may be available for refractory cyanosis. So the last lesion I'm going to discuss is tetralogy of flow with absent pulmonary valve. Dr. Lindblad and I chose the same exact diagram. As he already discussed, this lesion is characterized by a rudimentary dysplastic pulmonary valve, in which case you have to and fro flow across the pulmonary annulus that causes aneurysmal dilatation of the main and branch pulmonary arteries. That secondarily causes compression of your tracheobronchial tree, and then over time can also cause RV dysfunction. Most of these are associated with a ventricular septal defect and tetralogy of flow. So again, just showing you another example of it. Here you've got your right ventricle, left ventricle, your large anterior mal-lined VSD, and as you sweep up, you start to appreciate here's your aorta and very dilated main and branch pulmonary arteries. Color shows that to and fro flow, as was mentioned. And again, this is just a still frame image that's showing you how dilated those main and branch pulmonary arteries can become. And in a case report published in Circulation by Dr. Chalaya, she looked at the fetal lung findings. And similar, actually, to what Dr. Lindblad showed you, is that first you have mediastinal shift, so the entire heart is deviated more leftward in these patients. And then you have fluid trapping in the right lung that's manifested by this T2 very intense signal and compression of the left lung with left hemidiaphragm elevation. Here you can also see that there's tracheal deviation as well, and all of these findings become very important when considering how to manage these children in the delivery room. Now, interestingly, pulmonary artery size may predict high drops in these patients, but the cardiac enlargement and dysfunction in the lung pathology have felt to play a greater role in the postnatal survival, and some of that may be best estimated by the mediastinal shift, but more work remains to be done in that arena. Needless to say, these fetuses can come out with a lot of difficulty, and neonatology and or cardiology, again, should be present in the delivery room. With very early intubation with specialized ventilatory strategies, including placing the baby prone, hemodynamic support, because as was discussed, these patients often have ventricular dysfunction, and again, ECMO should be considered for those patients with refractory cyanosis. So in summary, a timed delivery involves coordination of care among specialists at a tertiary or quaternary care center. And I think it's important to emphasize that this does not necessarily require delivery at less than 39 weeks. For the first two lesions I discussed, hypoplast with intact atrial septum and transposition, most of those fetuses are going to be perfectly fine in the third trimester, and there's no reason to deliver them early. For the latter two, Epstein's anomaly and the absent pulmonary valve, they can become progressively hydropic, but again, later is always better. And I also want to emphasize that as a pediatric cardiologist, I'm certainly not going to tell the obstetricians how to deliver their baby. And so from my standpoint, when we say a timed delivery, that does not necessarily imply a cesarean section. But again, that's dependent on your institutional resources, the comfort of the high-risk OBs, and the availability of your cath lab and the rest of your cardiac team. I hope I've shown you a little bit that fetal echo findings with and without maternal hyperoxygenation can help stratify risk. And I just wanted to, I think these lesions have very complex pathophysiology, and so I just wanted to provide a summary here of those that I discussed that have difficulty transitioning, and what I mean by that really is providing systemic oxygenation. And I think it's important to remember that time delivery does not necessarily mean ductal dependent lesions. And so with hypoplastic left heart syndrome with a restrictive or intact atrial septum, you have inadequate cardiac mixing, and so you need an urgent catheter surgical-based intervention. Transposition of the great arteries ends up being a very similar entity for a lot of the same reasons. And then with Epstein anomaly, you have insufficient functional pulmonary blood flow and lung abnormalities that require a lot of careful medical management in the delivery room with use of ventilatory strategies. And then tetralogy of Fallot with absent pulmonary valve. Again, it has to do with medical management in the delivery room and early intubation and ventilatory strategies. So thank you very much for your time.